I want to thank you very much for this opportunity. And it is an opportunity to come home, and it feels like coming home to basically family and friends. I mean, Stanley, you still are my mentor, even now. And to have this opportunity to share work which is really, I won't say out there, but it's certainly the way I practice medicine is quite different than the way you do. And what I wanted to do is to share that with you. It was when I went into private practice in 2006 and then wrote a book, Dropping Acid, the Reflux Diet Cookbook and Cure, the idea that you could cure reflux, that the floodgates opened and I began to see patients, the likes of which most of you don't see. I'm going to talk about things that you don't see, like idiopathic pulmonary fibrosis. I'm going to talk about reflux, but I'm also going to talk about the vagus. So the title I gave the talk was Reflux, the Vagus, and the Voice, but even though most of this is going to be about the voice, it's really reflux about the aerodigestive tract. And the truth be known, the real title is The New Field of Integrated Aerodigestive Medicine. So, you know, it's interesting. One of the universities asked me if I'd start a program in aerodigestive medicine, and I had a couple of meetings, and they said, well, let's go ahead and get started. And I said, who are you going to invite? And they said, we're going to invite the pulmonologist and the gastroenterologist and the allergist. I said, whoa, we don't need all the specialists for this program. So the whole idea is that what I do in one institution is a field. It may not be the best way to do it, but I want to share that with you today. So who knows? Stanley, you know what that is, don't you? That's a giant Galapagos tortoise. And one of the things you know about the Galapagos Islands is they're Darwin's Islands. And actually, the Galapagos turtle is the world's largest. It's a 1,000-pound turtle. They've lived 170 years in captivity. And they come from this set of islands. They really are Darwin's Islands. And Darwin has written the most about how these animals basically evolved in isolation. So animals that are here are different than animals anywhere else. In fact, they're called the islands of the tortoises. And the very long neck is an evolutionary adaptation to increase vertical reach. So the plants that they like to eat grew taller with time, and so too did their necks get longer. So I guess my opening salvo is I have evolved like a Galapagos tortoise, so that a big part of me operates in relative isolation, and I've not published much of the material that I'm going to present today because it's too big. So you say, well, that's an anecdotal case. But if I told you I've seen 10,000 anecdotal cases just like this or in this group, that would be the truth. My practice is unusual. So, by the way, there's a great read, The Beak of the Finch by Jonathan Weiner, about Galapagos finches and Darwin and evolution. So first question, we have mostly people in our field. How many people think this larynx is normal? I got 10. How many people think it's abnormal? I got 4, okay? So this is a 28-year-old woman with a 2-year history of chronic cough. She has reflux-related and neurogenic cough. This is how she appeared at presentation, and here's how she appeared after treatment. So I maintain that reflux is so common in our field, in all of it, in sinus disease, in quote allergy, in quote every aspect, that it's invisible. Reflux is invisible. So the vocal folds should be thin, white, appear two-dimensional. They almost come up like a bow of a ship. The ventricle is very, very sharp and open and glistening. And the posterior larynx is thin and round, and as you see, so you realize when you look at these two pictures that this is edema. And the whole idea of red arytenoids is silly. It's not the main finding of reflux. If someone has red arytenoids, they reflux last night or the night before. The redness doesn't persist unless they've had nocturnal reflux within the last 48 hours. But I think what I want to share with you is this concept. The respiratory and digestive systems are thought of as being separate. But in the pharynx, it's the same, okay? You swallow and you breathe, and you basically have leaky valves. So this is the lung. This is the last way to prevent aspiration, the closure of the vocal folds. And yet, here's the trachea. And the cricopharyngeus. A lot of the GIs think there's no such thing as respiratory reflux. How could that be? The presumption that this valve is like a C-clamp, never to open, because it's not supposed to when acid comes into the esophagus. So this concept that the pharynx is actually grand central station through which everything goes is really an important concept. So this is a patient of mine. She's a well-known actor. She does TV, she does film, and she's seen 2 laryngologists. One gave her a PPI, and the other one put her on voice therapy. And so here you see the pharynx, the cobblestoning, the obliteration, the fossa Rosenmuller. The pharynx is granular and narrow. The posterior larynx is swollen. She's got muscle tension pattern 1. She's got perhaps paresis of her left vocal fold. It's subtle. Okay, but this patient's, look at the pharynx. It's granular and weeping all the way from top to bottom. That patient has nocturnal reflux. If I'm right, I'm saying 70% of respiratory diseases is reflux. I'm talking about all of it. Sinus disease, all of it. COPD. 70% of respiratory disease is reflux. And by the way, the term respiratory reflux, I coined the term LPR, and I'd like to coin the term respiratory reflux because it's a more intuitive term. Patients understand it. It takes it out of the GI realm. And laryngopharyngeal reflux, or LPR, is a mouthful. So respiratory reflux I'm going to use going forward. GIs and ENTs are uncertain how to diagnose and treat it. Part of the problem is the GI heartburn business model was created in the 70s. Looking in the esophagus doesn't tell you whether a patient has reflux. It tells you whether a patient has esophageal disease. GI tests don't tell you what's happening in the pharynx. And the treatment, as you'll see, for me, proton pumps stopped being used in 2014, PPIs. Almost every aerodigestive tract symptom is a vagal symptom, and I want to talk about the vagus in particular, and that vagal neuropathies and neurogenic syndromes are ubiquitous. I did a study, never published. I took patients with SD who obviously have a central problem, and I did diagnostic EMG before I did the first Botox injection, and 40% had paresis, many of them bilateral paresis. So we think that I have a paralyzed left vocal fold. Post-viral vagal neuropathy, sick with the flu, Christmas Day, 1997. So that's why I'm so breathy. So vagal neuropathies are very common. So the idea that these patients who come to see me, they can be diagnosed and they can be treated. And I often say to my patients, if I didn't get good outcomes, I'd just be a crazy person. Because if you take a paradigm that is outside the norm and apply it, and you're not getting good outcomes, then something's wrong. These are 20 common, actually reflux-caused misdiagnoses and enigmas, and I haven't included cancer. There were several papers presented today, and I kept saying reflux, reflux, reflux as the slides went up. But I will make a comment about aerodigestive cancers, which I believe will be proven someday. You can get aerodigestive cancer without smoking, but not without reflux. That you can, if you don't have reflux and you smoke, you're not going to get cancer. So let's say a few things. The otolaryngologist ought to be able to distinguish the postnasal drip and the allergy patient. These people have attacks. If you examine them, they have boggy nasal mucosa. The mucus is always crystal clear, thin, whereas mucus with reflux looks different, and you see cobblestoning. Asthma may come as a great surprise to you as otolaryngologists, but most pulmonologists don't know that trouble breathing in isn't asthma. I had recently a patient, I told my pulmonologist, and he was so impressed with that idea, that asthma is only expiratory, wheezing. And so it goes. Glottal closure symptoms, I'm going to talk about more. Chronic cough is 1/3 of my patients. I wrote a book called The Chronic Cough Enigma because I couldn't get the article published in the annals. I was told this is beyond the scope of our journal, meaning this was many years ago, don't want such a paper. Sleep apnea is a big one. I'm going to show you some pictures of what sleep apnea looks like. And this vocal cord dysfunction is a non-diagnosis. This is the diagnosis of someone who doesn't know how to look at the larynx. but we see laryngospasm and paradoxical vocal fold movement quite commonly. In terms of the neurogenic, certainly neurogenic cough is the most common, although among my population of chronic cough patients, only 10% are neurogenic only 40% are reflux only, and 50% are reflux-related and neurogenic. Throat burn is a neurogenic symptom. In fact, sore throat is pretty much a neurogenic symptom. You may be a little sore if you wake after a whole night, but if someone comes to you complaining of sore throat as a primary, particularly if they're dealing with pain, throat pain, it's probably a neurogenic symptom. We're going to talk about that more in a moment. And all these glottal closure. So the odynophonia, or painful speaking, a term I made up, like odynophagia. Odynophonia is a neurogenic symptom. It's not from reflux, okay? And all of these symptoms can be alleviated with treatment for, and this is very important to know, because I used to operate on all these people doing bilateral medialization laryngoplasties, but not anymore. Honorable mention for neurogenic in our vagal areas, ear pain, atypical chest pain, and burning tongue I just put on there because when I was a resident, the least favorite patient you wanted to see is an elderly woman with burning tongue. It's neurogenic, and they respond to the same kind of medicines that I'm going to present here. So this is a dog on a chain, and here's a cat. And I feel like this dog on a chain many times and have in my life, and I've persisted. So the caption, if you can't read it, is let me preface my remarks by saying the chain is a lot longer than it looks. The specialist model of American medicine has failed. It's not failed for the miraculous stuff. If you're a great surgeon like Peek Woo, you're doing the right thing at the right place at the right time for the right patients. But for all the common things, for people with chronic throat clearing, for people who have reflux disease, for people who have respiratory reflux symptoms, globus, dysphagia, all the symptoms I'm going to put up, the specialist model doesn't work. Virtually every patient who comes to see me has already seen 19 physicians. Many of them have been to major, well-known academic institutions all over the country. So the whole idea is that we have this question about what to do with healthcare and fix healthcare and heal the nation, I believe, with this whole question of common good and how do we address it. And I think integrated aerodigestive medicine could be a piece. Right now, we're spending 18% of our GDP on healthcare. That's $10,000 per man, woman, and child. It's more than twice any other country. By most metrics, we are ranked dead last in terms of quality metrics. That is, longevity, infant mortality, deaths and complications after surgery. I don't want to belabor this. I do want to point out this as we enter the political year, that any big change in healthcare is a bad idea. You can't have Medicare for all. It would bankrupt the country. You can't get rid of the Affordable Care Act. And so incremental changes. So this may be a big incremental change. So here's one, and here's what I originally proposed. I wrote a piece in the New York Times 2 years ago, The Specialist Stranglehold of Medicine, in which I said, re-empower primary care physicians to manage all common aerodigestive diseases and specialists by referrals. This goes back to an older day. We know that PCPs who really do a good job, their patients get better care and less expensive care as well. And now the more I think about it, maybe integrated aerodigestive medicine should be a branch of our specialty, or even possibly a non-surgical tract within otolaryngology, because you're going to need to do endoscopies. You're going to need to be able to look in the larynx, you're going to need to be able to look in the esophagus, you're going to need to be able to look in the lung. I do all those things. I got scopes with beautiful distal chip cameras. I've been doing transnasal esophagoscopy since '99, every day, without batting an eyelash. If you haven't ever looked at this article by Gwendy, and he's also written the article that shows the primary care physicians are a good thing. The cost conundrum is very interesting, and it talks about the overutilization of expensive resources. And without one physician who's responsible for the care of the patient, the system has no brakes. So when my patients come to me and they're seeing pulmonologists and gastroenterologists and allergists, I say, let me take care of this for you. And I then contact and deal with the physicians that are involved as needed. So these are the things you're used to seeing. And as you see, I've put little daggers on here for the ones that may be neurogenic. And then, of course, these we could add. And by the way, this list could be so big it wouldn't fit on the slide. but idiopathic pulmonary fibrosis, maybe it's not idiopathic. Throughout this talk, what I'll do is I'll offer you as best I can what I think are pearls from my practice. For all intents and purposes, wet cough is reflux and dry cough is neurogenic. So a patient comes to you with just a dry cough, they probably don't have reflux. How do you say gastroparesis? So this has to do with the vagus. So is my practice really that different than yours? This is a needle point, small, it's in the front of my office, and here's the story. An 80-year-old woman came to see me. She'd been coughing for 60 years. She didn't cough a little bit. She coughed all day, every day. Never coughed at night. She coughed when she talked on the phone. She coughed when she had any kind of change in temperature, environment. Never been to a movie theater, never been to a restaurant. Had a husband, did a lot of cooking, spent a lot of time at home, had friends with whom she played bridge. I examined her. She had no reflux. She had mild bilateral vocal fold paresis. I did do an EMG. She had an old viral neuropathy pattern, meaning all four. I said to her, have you ever heard the term neurogenic cough? And she said, no. I said, well, you're a little bit older, so I'm just going to put you on a little medicine tonight, and I'll call you tomorrow. So I put her on 10 milligrams of amitriptyline. And I called her the next day. And I said, how you doing? She said, good. And I said, how's your cough? She said, good. I said, good as in better? She said, no, good as in gone. One pill. She still takes 10 milligrams of amitriptyline every night. So anyway, she made for me this needle point. So I now practice otolaryngology, but I know about parts of otolaryngology that not every otolaryngologist knows about. Same thing about allergy, gastroenterology, pulmonology, speech-language pathology, and I'm part neurologist. So what do I have? We used to call this transnasal fiber optic laryngoscopy. Then we called it TFL, transnasal flexible laryngoscopy. But now it's transnasal pharyngoscopy and laryngoscopy with or without stroboscopy. Why? Because the pharynx is so important. I'm sorry we didn't talk about it before now. We've been doing, if you go buy yourself a $1,000 pH-METRY for your lab, you're going to get an ISFET chip. This chip is in the pharynx as well as one in the esophagus. So we've been getting high-quality pH data out of the pharynx now for the better part of 15 years. All of our patients are tested. High-definition manometry, pharyngeal UES manometry is really interesting. In patients who have globus and dysphagia, the single most common pattern is a hypotensive UES, but premature closure during the swallow, often with a high peak pressure after the swallow. And some of them will gulp. Laryngeal electromyography, diagnostic electromyography, I make more decisions based upon the EMG than anything else. Transnasal esophagoscopy, it's a functional exam. You can look and see what the lower esophageal segment is doing, not just if they have pathology. And pulmonary function testing, I could add more. We do body composition analysis and a bunch of other stuff too. And of course, we send patients out for the usual other tests. So this is, and you could add bronchoscopy to this, I'm sorry. But this is pretty much what an integrated air-adjusted medicine center has in terms of technology, good technology. I've given you two things. The glottal closure index, people are using the reflux symptom index. Just pass those along. This is sort of this page is the part of our return patient visit. But we've looked at the glottal closure index with the reflux symptom index. Every patient, every visit since the 80s. And the glottal closure index turns out to be really important. It tells you which patients probably have paresis and vagal neuropathy. And on the other side, you'll see the chronic cough index. And I'll get to that in a minute. So for all intents and purposes, when the glottal closure index is higher than 10, it's not just reflux. There's something wrong with their vocal folds. It may not be paresis, may have a hemorrhagic polyp, but they've got a glottal closure problem. And here's the reflux symptom index. So we use them both together. So I want to show you this. This turns out to be really interesting. I marked this one up. So on the left, you see the yeses. They're all reflux symptoms. And on the right, you see the yeses. They're all neurogenic symptoms. If a patient with cough came in your office and filled that out, you'd say their reflux to neurogenic ratio is 50-50, and they probably have both. Normally, we just count the yeses. So it might be 1 to 4. See, that's neurogenic, but maybe some reflux too. But with one instrument alone, this is highly useful, and I recommend it to you. if you have patients with chronic cough. The patient who came to see me, the old lady, she was a reflux to neurogenic ratio of 0 to 10. So now I want to share with you a little bit of my evolution. This is one of my epiphanies case. So same year as my paresis, in 1997, a Washington big shot came to see me with severe painful speaking and reflux symptoms 1 year post upper respiratory infection. And I mean, he was disabled. The pain went to his jaw and palate, it was a bad situation. He came to see me and I said, you know, you got reflux, but this is nerve pain. And and you can see, look at lovely laryngeal biomechanics. I mean, you know, for a person with profound glottal closure symptoms, that's not bad. I mean, those close. So because he was a big shot, and he had an EMG, it showed a neuropathy, we flew to Boston to see a nerve doctor. And the nerve doctor said, it's nerve pain, it's vagal, it's vagally mediated. She put him on gabapentin, and of course that was many years ago. But what I'll never forget is as I was walking out of her office, I'm thinking to myself, rush hour, getting to Logan, she says to me, the vagus loves gabapentin. And I'm thinking to myself, what does that mean? It's like a better medicine for the vagus than for other nerves, about diabetic feet and all that, and I started thinking about cough patients. This wasn't a cough patient and burning throat patient. So anyway, I left Boston on a Thursday night, and at home, actually Sunday morning, I got up and I opened Netter. And I had an epiphany. This is the vagus, all of the throat, the vocal folds, the upper valve, the esophagus, the lower valve, the stomach, the liver, the heart, the intestines, the ear, and all of the respiratory system except for the diaphragm. So when I show this to patients who have vagal neuropathies, I test them. I go, okay, you tell me what nerve, and I explain the cranial nerve. The 10th cranial nerve is the longest and most important of the cranial nerves. So like heartburn, vagus, cough, vagus, vocal fatigue, vagus, asthma, vagus. So when you start thinking this way, it makes sense to understand that people who have nausea and gastroparesis may have had a vagal neuropathy, and that's, you know, and the stomach stops, they have reflux, and all these things are connected. So knowing something about that makes sense. So all this stuff is connected. So in a way, the vagus is the aerodigestive tract, but it's important to remember that it's the vagus, it's the nerve. So although it controls both symptoms or provides information in the brain about symptoms and function, it's also just a nerve. But all these things, neurogenic and reflux-related cough, really maybe all reactive airway disease except allergic rhinitis. So I've listed these things again, and we talked about globus and dysphagia and LES function. So, you know, a 24-year-old school teacher comes to me. She was sick in August last, had pleurisy, sick for 3 weeks, seems to recover, goes back to school. She has no voice. She's just struggling by the end of the day. She's got a cough and she's got reflux. Never had a voice problem, never had a cough, never had reflux. Terrible vocal fatigue. Post-viral vagal neuropathy. So here's a real case. I see these cases a lot, and I share this one with you because I want to talk about some of the details. So this guy is a 54-year-old school teacher. He's basically can't teach. Sorry, these got kicked over again, but he's got throat discomfort at a 5, and his glottal closure index is 15. He had an upper respiratory infection, and one ENT put him on twice-day Prilosec, and he was unable to teach. And here he is. This is tremendous post-cricoid edema. And here you can see, so he's got massive reflux and a left vocal fold paresis. And it actually is, a lot of people are called by otolaryngologists or laryngologists, they have a unilateral paresis. But when you do EMG, most of these people, it's bilateral. And you think about it for a minute. If this is comparable to Bell's palsy of the throat, is the virus just going to say, ooh, I think I'll just do the right side? So we tend to see a diffuse polyneuropathy. But there's not much question about the reflux and paresis in this patient. He doesn't have any heartburn. Only 20% of patients with reflux have heartburn, which means 80% of them don't. And most of them have respiratory reflux. So here's something you've never seen before. This is a pH study. This is nocturnal reflux all night long. Same thing in the pharynx. This is esophageal tracing and pharyngeal. Look at the mean pharyngeal pH. Normal is 6.8, so it's logarithmic, so this is huge. Look at the mean, and by the way, they're not terribly different. Look at how many reflux episodes, but this is really only one reflux episode all night long. So we call that the puddle pattern. And that's not detected by impedance, period. And this is very common in today's patient. Nocturnal reflux, silent reflux is all night long. And I'm going to show you what it looks like. He has esophageal dysmotility and no valves. And I say to patients like this, you are like the Holland Tunnel with no tolls, not even an easy pass. When you lie down, what's in your stomach is in your esophagus, is in your throat, is in your nasopharynx. It's everywhere. And it is. So this is going to sound extreme. I want him to go to bed with an empty, quiet stomach and sleep on a big enough incline that gravity really matters. By the way, I have an older woman who had chronic cough, who runs her own business, and I just basically said, you're going to have to sleep in a chair the rest of your life. And she's going to be 100 this year, and she's got no LES. And when she started sleeping in a chair, her daughter got like seat belts for her recliner so she could do it. Her cough went away. So anyway, so we're 5 hours and 45 degrees, low acid, low induction diet, no alcohol, nothing out of a bottle. Alkaline water is the only thing we have that actually kills pepsin that's safe. And we use ranitidine before breakfast, dinner, and twice before bed. That's it. Haven't used a PPI since 2014. They don't work very well at night anyway, and most of these people have nocturnal reflux. And Gaviscon Advanced, which is very helpful. That's all there is to it. Not easy to do, but you got to sell it as a detox program. He had the EMG, the usual EMG. So what I do is I put him on 5 or 10 milligrams of amitriptyline. Amitriptyline makes gabapentin work better at low dose. And I explain I'm putting you on 10 milligrams of amitriptyline. It's an old-timey antidepressant. I'm not putting you on an antidepressant. 10 milligrams wouldn't make a fly happy. But I escalate these people, and I talk to my patients. One of the things about being in private practice is we take care of these folks. And I say every time you change doses significantly, ask yourself, am I better, worse, same? And am I having any side effects? So we run a big range of how these patients do. So here's the same guy. He gets himself up to 800, and his glottal closure index is now 4. He says, I can teach, but I can't push my voice. His reflux has gone from 18 to 11. Here's the same guy 5 weeks in. He's still got vocal fold paresis and reflux. He's got no symptoms. He's full on. He's actually coaching soccer as well, down to 7 on this program. Here's the guy, by the way, at 5 weeks. He's still not great, but he's got beautiful closure, even though he's got muscle tension dysphonia. But this is a man who's asymptomatic. So this whole idea, and by the way, his EMG was interesting. I went by it quickly. But he had a predominance of low amplitude polyphasic, so-called nascent motor units, indicating ongoing neural recovery. So he may have had some degree of spontaneous recovery. But I put him on amitriptyline and gabapentin and ranitidine and all that. So this is a very common patient. And I want to impress upon you that post-viral vagal neuropathy happens all the time. If you ask patients when their symptoms started, if they've been sick with a flu or the cold, many of them will tell you very elaborate stories and the sequence of symptoms and how they occurred. And I tell the patients, you ever seen Bell's palsy where the face droops? Well, that's a virus, gets in the nerve, makes it swollen. So the vagi live right under the lining of the throat, and some viruses are surface viruses like rhinoviruses, and other viruses are aggressive like, say, Coxsackie from upstate. So we think this is quite common. And by the way, they may look like they've got a unilateral paresis till you do the EMG. So I'm telling you, so this is, the kind of stuff, you try to publish this and you're going to get, nobody's going to believe you. 75% of my patients have vocal fold paresis. And by the way, 15% of paresis patients don't have asymmetry because they have bilateral paresis, but they've got muscle tension patterns to get closure. 40% of normals, I've mentioned this, and common neurogenic symptoms, glottal closure symptoms, odonophonia, throat burn, and all the like. So right now, my patient group runs from 200 milligrams as an effective dose to 12,000 milligrams. And I'll tell you one quick story. I had a woman who came to me with throat burn, young, a very thin, small woman from Kansas City. Anyway, I saw her last July, a year ago, And I upped her to 3,200 milligrams, no, 4,800 milligrams 5 times a day. And she was miserable. She had real pain. She comes back to see me in the fall and all smiles. And I say, so everything's good? She said, everything's good. I said, how much gabapentin you on? And she said 8,000. She kept going back to her family physician and getting more and more and more until she finally got relief. And this has more to do with bioavailability than number. Who makes a drug, 100, 300, 400, 600, 800 milligram pills? There is trouble with some insurance companies paying for the higher doses. I wanted to share this case with you because I think it's a good one. This is a 38-year-old attorney from Providence, Rhode Island, who's had bronchitis and shortness of breath. And so I see a lot of people with real respiratory diseases, respiratory reflux. He had all the whole shamil. And he was flying back between 2 renowned academic medical centers, one in Boston and one in Denver. The problem was that he had another problem. He was anemic. Who knows why he was anemic? He was anemic too. This guy with chronic 38-year-old guy with chronic bronchitis. He was coughing up blood. So there he'd be on the plane coughing and trying to reveal the fact that he was coughing up blood. And here he is. Nice picture. Nocturnal reflux. Now, this is a new finding. In the reflux finding score, I've only changed one thing. Post-cricoid edema gets you 2 points, but if it goes all the way to the posterior pharyngeal wall, it's 4 points. And here's his trachea. My system doesn't show up red, and he wasn't coughing up blood that day. But anyway, to make a long story short with this guy, and we evaluated him. He had terrible reflux. He had terrible LES function. I sent him for fundoplication. 6 weeks later, he was well. He was back for his 1-year follow-up visit last month. So I want to show you this. It's sort of interesting. We talk about nocturnal reflux. So you got cobblestoning, partial obliteration of fossa rosemola, cobblestone weeping pharynx, the big posterior commissure. But let's take 2 of these photographs and flip them around. This is what happens at night when he's asleep. This is what's down. And here's why we see post-cricoid edema like this in patients who have nocturnal reflux. Last case. So this guy comes in to see me because he's got postnasal drip and chronic throat clearing. That's it. Wall Street guy. Doesn't have any other complaints. Previously had balloon sinuplasties. Forgot about that. And the GI told him he had Barrett's. So here he is. He's got pseudosulcus, ventricular obliteration, erythema. Whole thing is thick. Looks like a left vocal fold paresis. How many people here do laryngeal examinations with a rod as their first exam? How many people routinely do transnasal exams? If you're not doing a transnasal examination, you can't make a proper diagnosis. To ignore the pharynx and the nasopharynx, I'm saying this basically as of June 2019, you gotta look at the pharynx, gotta. So look at this. I looked at the guy and I said, by the way, do you snore and you have sleep apnea? And he said, yeah. So you can diagnose sleep apnea. All the time I'm saying, patient, you didn't tell me you have sleep apnea. Oh yeah, I wear one of those masks. This is pH-1 in the middle of the night. This is a pharyngeal reflux episode from hell. Look at the mean pharyngeal and esophageal pHs. Here's what he looks like. He's got a patchless EE junction, a regular Z line. And you can see we've biopsied right on the edge of that with a CDX. I love the CDX. It gives you a disaggregated full thickness biopsy with about 300,000 cells. And so T&E is a functional examination. We don't kill anybody. The patients walk out the door. We do this well. GIs are overdiagnosing Barrett's. The problem is the patient's asleep with a collapsed tube. After the first biopsy, there's blood in the field, and they keep on snipping, and they get too low. For every 3 patients who comes to me with Barrett's, only 1 of them has it. And here's what you get. And if you do a really good biopsy, you get squamous and columnar epithelium. You're right on the edge of it. So T&E is important, and otolaryngologists should be doing it. And this guy gets the same kind of treatment. PPIs work well in about 57% of patients with heartburn. In my patients, they work in 0%. They're all on or have been on PPIs. If you think about it, there's a certain amount of arrogance in the idea of treating people with a proton pump inhibitor for reflux disease, since in the stomach the proton pumps make acid, hydrogen ions. But what about the proton pumps in the kidney, in the brain, in the heart, And what we're now seeing, and I have a website, Voice Institute of New York, and I have a blog on this that lists all of the references. But I stopped using the PPIs. The Danish study showed 10,000 people prospectively studied long-term use of PPI increases your risk of esophageal cancer reflux cost. Long-term use of PPIs increases your risk of cancer. And I went, duh. Just takes away some of the symptoms and eat whatever you want. Have the disease go on unabated. This is the Danish study. I was in Copenhagen lecturing, and I put this slide up, and two hands went up in the back. Two of the authors were, and I got a chance to meet them. There's a VA study. It's not a very well done study, but the sample size is large, where they looked at the PPI takers versus the H2 antagonists. The mortality is 25% higher in the PPI group. So back to the question, what I want to finish with here is the discussion of the findings of nocturnal reflux and go over what I think is going to be useful information for clinicians. So post-cricoid edema, so the back that, remember we've just talked about that. Cobblestoning, erythema, obliteration of the fossa in the pharynx, cobblestoning. Oh, by the way, the large uvula, I didn't show you, but the uvula resting on the tongue base is an absolute finding, which we see every single day of nocturnal reflux. And even if they come back 2 weeks later after a detox program, the uvula will no longer be sitting on the tongue base. So here's a patient who's got post-cricoid edema and posterior commissure hypertrophy. And so my question is, if you saw that patient, would you be sending that patient for a CT scan? I would not. So here's our normal. Here's the guy we just saw. And here is here's post-cricoid edema, but here's post-cricoid edema that goes all the way to the posterior pharyngeal wall. You see the secretions pooling in the hypopharynx. This guy's got UES dysfunction, globus 2. This is really where there's so much post-cricoid edema that it's falling in. You see the pseudosulcus, ventricular obliteration, erythema, nice pseudosulcus. And here, again, but I want to show you, this is why we call it tiger striping. But this one's really interesting because this is a patient who only refluxes at night. Look at how nice her vocal cords look. Look how nice her ventricles look. Look how nice her aryepiglottic folds are. But look how not nice the back of her larynx. So she'll only score 6 points for this, maybe 2 for that, 8 points, which you'd say, gee, and I say patients in Jamie land, a reflux score of 10 is not that bad, above 10, not that good. But this is a very common patient, and I'm pointing out to you these nocturnal refluxes are important to identify. I sent a bunch of you this photograph in 2006 with a question. I got a patient who's got this real cobblestoning, a reflux patient of mine, young guy, he was a 30-something-year-old guy, and I sent it to my friends, I sent it to Bob, and I got nothing. I didn't even get a response to the email. Erythema, cobblestoning, obliteration of the fossa rosenmuller. So these are findings. So you would say, well, anybody who smokes looks like this. And the answer is, so challenge me. Tell me something. So when I finish examining the patient, I say to the patient, you should ask me what else besides reflux could make it look like this. So the patient goes, well, what else could make it look like this? And I go, nothing. This is what nocturnal reflux looks like. And of course, these are the pharynges that go with it. I think you should know smoking doesn't do that, okay? Allergies don't do that. This is reflux disease. So to finish up, the consequences of fragmentation of the aerodigestive tract. Oh, by the way, I asked patients this. Do you know why the specialties are created so there's no overlap, so that each one has its own little discrete box in which to operate? So doctors won't kill each other. It's about turf. So I'm on everyone's turf. Gastroenterologists are not thrilled, I can tell you that. I said to a gastroenterologist, I'm writing a chapter now for a blog called Gastroenterologists Are Like Dinosaurs, only unlike dinosaurs, they deserve to die out. I said that to his face. He didn't bat an eyelash. He said, we didn't like you before. I think that the heartburn business model, you need to recognize I'm talking about reflux. They may be great, at other things, but when you're talking about other things, this is a business model. You get the 15 endoscopies done by noon on Friday so they can get to the house in the Hamptons before traffic. So I just think that once they become endoscopists, they stop becoming physicians. Everybody gets the same treatment. And so you understand that this is not going to help you with your respiratory reflux patients. And so, you know, it's a problem when the go-to doctor isn't going to get it done. So my point is the aerodigestive tract is physiologically connected, anatomically connected, and all these diseases, in my experience, seem to be connected. And so who will practice integrated aerodigestive medicine? And of course, as you know, I've added the element, or at least more so, of neurogenic. I think this is, the vagus is the seat of the soul. It's important in absorption. It's important in immunity. Just a recent article in the Times, somebody was saying basically this, the seat of the soul. I wanted to have a vagal reflex testing laboratory way back when, but I couldn't do cell biology and this. So anyway, I leave you with these thoughts. I hope this has been useful to you. And maybe we can make an integrated aerodigestive medicine program. Thank you.